Professor Isaac Adewole, welcome to Hard Copy.
Thank you, Maupe.
There are so many areas to talk about when we're talking about health issues in the country. Only recently, you banned codeine on the back of a BBC documentary. And that's what a lot of people believe, because it was a day after that documentary aired that that ban came in. We also see that JOHESU has been on strike. The joint health sector unions have been on strike. And then there's also been the question of funding. A lot of areas to talk about. Let's talk about your tenure so far. I mean, you've been there for over 2 years plus now.
Yeah.
What precisely has been your focus, considering the plethora of issues facing the healthcare sector?
Thank you so much for the opportunity to appear on your program. When we came on board, we were quite concerned about doing an appraisal of the health system, doing a diagnostic, what exactly is wrong with the Nigerian health system. And certain things came out clearly. One is the fact that we need to change or reorientate the architecture of the health system. The health system can be likened to a pyramid sitting on the tip. And what do I mean by that? The real pyramid has a base, and that's the primary care. There is a mid portion, which is the secondary care, and the tip is the tertiary care. Unfortunately, the primary care is meant to be funded by local government, State, and they're not getting the desired attention. Many of the local governments are not functional. The mid part, which is the secondary, is not getting deserved attention in many states. So the only part of the pyramid that is receiving attention is the tertiary. And so most Nigerians would rather leave their home and enter into a tertiary system. And we thought that was unacceptable. And so the first thing we did was to say, we need to change this pyramid. Let it sit at the base. And we came out clearly with a new philosophy, which is not new, but we restated an old philosophy, which was abandoned, that look, let's have a proper pyramid. Let's put emphasis on primary care. And then, fortunately for us, in 2014, the previous administration launched an initiative on universal coverage, which implied that you get health where it is needed, quality health care, without you becoming impoverished. And so we said to achieve that universal coverage, we will use primary care as a platform.
Universal health coverage was launched in 2005. Was it not under the administration of President Obasanjo?
2014.
Was it in 2014? Because
Yeah.
I recall...
That's when we had there was a presidential summit.
There was
universal coverage.
There was Professor Eyitayo Lambo.
That was the national health insurance. That was the insurance scheme.
Oh, that was the insurance scheme, not for universal health coverage.
They are intimately related,
yes,
but they're not the same. You need the insurance to achieve universal coverage. When you look at coverage, we said you get health, quality health care where it is needed, when it is needed, without you suffering financial hardship. So that means there must be a form of payment. And so there are two ways to fund it. Insurance, where you make those who are healthy pay for those who are sick, and those who are wealthy to pay for those who are poor. The other one is to put public funding. But both must work together. You cannot really separate one from the other. All over the world, health enjoys funding from public sector.
You talked about how you were trying to turn the pyramid around and focus more on primary health care.
And then we moved
yes,
to formulating a national health policy. There has been 3 policies in the history of this country. The first was in 1988, the second one in 2004 under Professor Lambo, and the third one, which was approved by Federal Executive Council in 2016, became the third and the best, even according to Professor Lambo, the best in the history of this country. And what did we do in the policy? We clearly linked health to attainment of socioeconomic development. And we titled the policy as National Health Policy to Achieve Socioeconomic Development. And the committee that midwife the presentation and the preparation happened to be the same Professor Lambo.
As you're aware, thinking is usually never a problem for us. We usually have the best ideas. Usually the problem is implementation and following through. You talked about 3 national health policies that we've had so far in this country. Which one of them would you say that we've ever followed through? And what is the guarantee that we will follow through with this one that you launched?
That's the difference, because we've moved from the policy to developing a national strategic health development plan. The plan will cost activity by activity what you intend to do being driven by the policy. And so that is being costed. We're doing a nationwide dissemination with stakeholders approach. When we cost it, we take it forward. But what is also good is that we have an administration that is quite concerned about making health one of the key achievements of the administration.
It's going to be difficult to prove. I mean, only recently we listened to American philanthropist Mr. Bill Gates talk about investing in health and education of citizens, and he was speaking based on his first-hand knowledge of the workings of how health has gone in Nigeria. As we currently speak, we have agreed to the AU declaration in 2001 that we're going to be pledging 15% of our budget. This year in 2018, we're doing 3.59%.
Let me see. No, this year, which year are you talking
2018.
about? The budget has not been passed.
Has not been passed.
I think you should wait for the budget to be passed.
But the proposal
and you'll be shocked.
The proposal that we have pushed forward to the National Assembly
can I just advise you?
4%.
Can I advise you to wait until that budget is passed? You'll be shocked. That will probably be the best for health in the history of this country.
So it's not so much about the percentage?
Just wait. Don't be in a hurry. Let me tell you clearly, when we came on board, this administration promised and intended to move the funding to health up. But we were in recession. When you are in recession, you start scrambling. You want to get out of recession. Now that we are out of recession, I can tell you that the funding to health would dramatically change on the positive side.
Yeah, but I mean, the best that we have done so far is 7%.
This is the first.
Are we really
this is
putting
our best.
our money where our mouth
This is our first year after recession. Wait for it. What we've done is to spend our way out of recession by investing in needed infrastructure. But let me also say clearly, people tend to forget that health is not about drugs alone. Health is about food, health is about water, health is about electricity, health is about infrastructure. And all those things have positive impact on health. That is a wrong conception to believe that everything about health is the hospital. No. Yeah, but in fact, 80 to 90% of it is outside the hospital. It's about your environment. Where do you live? Getting food, sleeping well.
I totally agree with you. Very true. I mean, the environment is extremely important, which is where we will definitely ask questions on the environment. I mean, how are you working with other ministries, for instance, that are closely related with health? But let me quickly take you to this issue. You spoke at that expanded NEC meeting, and you were very frank when in your speech when you admitted that Nigerians have not quite gotten the healthcare system that they deserve.
That's correct.
And
nobody has denied that. Not even the leadership of this country. And if we have the healthcare system that we deserve, nobody will be talking about improvement.
True.
In fact, when I was vice chancellor, a boss of mine said, better is better than best. Because when you say it's best, you are leaving no room for improvement. But we will be honest to admit that we want to take it to the next higher level.
So one of the things you asked for was more funding, yet you say, wait, 2018 budget is going to be a surprise.
Number one, when you look in terms of the quantum of resources allocated to it under this administration, it's gone up. When we came on board, we moved the funding to 258 billion from less than 200. By the second year, we won 325. In 2017, we won 357 billion. But when you look at it as a percentage, then you think it's going down. But in terms of real allocation, it's gone up. And secondly, we also changed the direction of the allocation. We moved from curative to preventive. We are putting more money in prevention. What you have is not all that came to health. In addition to the budgetary allocation, the president released the 9.5 billion for polio. We got 3.5 billion for measles campaign. We got an additional 1.9 when we had the problem with other outbreaks. So when you add this together, it's really more than what you saw in the budget.
So what do we say to the primary healthcare unit per political ward, which we were looking at initially, which was like an intervention into investing into where the local government and state government have not been doing as well as they ought to. In some instances, they've totally failed.
The intention has not failed. Intentions don't fail. It is plan that fails. The intention is to make sure that we put emphasis. Number one, we can't do it alone. We brought out this intention and we're negotiating, talking, and networking with the state governors, and many of them actually are on top of the job.
So how is it going?
Kaduna has done 255. The last time in Niger, they've done 40. Borno has done about half of their PACs. So we are moving on. But we are also going to use the Basic Care Provision Fund to drive this. And I can assure you, our target is 10,000. It's not even it's not the maximum. It's the minimum.
Where are we in that 10,000?
Well, in terms of the 1,000, we are close to about 3,000 plus. Because EU is committed to doing 774. The DFID, funded by British government, is doing 950 in the northwestern states. So when you add all the NSHA program is about 1,000. When you add this together, we're over 3,000. But what we want to see is that side done by government to also match that side being done by the donors.
Quickly, let's talk about the environment. Only recently, I mean, in Rivers State, they had the problem of soot taking over, many parts of the state. The people put their clothes outside, they see soot, they sleep in their houses, they're seeing soot everywhere. As a Minister of Health, are you concerned about this development, and what can you do?
Well, it's not even what can you do, it's what have I done?
What have you done?
I've invited, because of the peculiarity, the political terrain, I didn't want to be seen to be doing it on behalf of government. The government is APC federal. They stayed there as PDP. So what we did was to call in UNDP and WHO to go there and do a scoping mission. And that mission is on. But I can tell you clearly, there is a complex situation in Rivers State. There is the burning of tires. There is the destruction of illegal refineries. So there are many things contributing to this. So we will need to partner with the state, federal, state, and international committee to address the problem.
Yeah,
and
but
that's ongoing.
In the meantime, I mean, of course, largely that's going to be trying to tackle the soot at the root level and seeing how it can be stopped. But in the meantime,
that's the best solution.
True.
Stopping it.
Some people argue it's long term. What is happening in the meantime?
It's not. In fact, stopping it is short term. But unfortunately, the long term is to stop illegal refineries. The short term is to stop the destruction, the bombing. Because what happened is that government goes there, the naval task force will go there and destroy illegal refineries. And when you burn those refineries, you have the soot. So
is there any word to soldiers, to the people who are working, security operatives, that there should be a directive?
It's been discussed at the Federal Executive Council. Government is concerned. And I can assure you that we will address this squarely. It's been given to the Minister of Environment as a major task to be done.
I'm wondering what's happening in the meantime, because whether or not we like it, people are currently inhaling this soot. And if they do it, even if it's just for a month or thereabout, it will definitely have effects.
We're not going to do a fire brigade approach. The fire brigade approach is to say, oh, you guys put on a face mask, which you find even in China, in Japan, people put on face mask. That to me is a short term, because you need to protect yourself. Are we
providing it? Are we taking it to schools?
We're working on it, putting out advisory about what can be done. But you also know that the terrain is complex. But I can tell you that the last FEC meeting last week, it came up, and the Minister of Environment is doing a lot about that. I think just give us a few weeks, you see the effect.
Well, let's take a moment now. When we come back, we'll continue with the conversation. Please stay with us. Honourable Minister, after a BBC documentary, a recent BBC documentary showing the effects of codeine abuse on Nigeria's youth population, your ministry banned the importation of codeine and also said it should not be used in the preparation of cough syrups. Would you say that your reaction was knee-jerk?
It wasn't, because we've been on the codeine matter for about 5 months. We were first alerted by the National Assembly. Thereafter, civil society organizations came to the ministry. And on January, I think to be precise, January 28th, we constituted a codeine working group. The working group was chaired by the Dean of Pharmacy, University of Ibadan, Professor Deco. And I gave them 6 weeks to submit their interim report. We did not come in until April 12th. But immediately after April 12th, we sat down to say, look, how do we address this issue? They made short-term, mid-term, and long-term recommendations. And short-term include, we need to look at the supply side. Because tackling the codeine issue must take a comprehensive approach. We need to look at production, we need to look at distribution, we need to look at sales, we need to look at consumption, treatment and rehabilitation. And the recommendation, to be precise, is far-reaching and to me, very helpful. I knew the documentary was coming. The documentary has been helpful. The documentary did not make us ban codeine, but it has helped us to zero in on the 3 companies that were identified. We will have made the recommendation general, ban codeine, but we would not have been able to come hard on the 3 companies. But BBC documentary helped us. So we knew the 3, and that helped.
You didn't know the 3 before then? I mean, there had been
Because
investigations, haven't there?
No, the 3 are not just the only 3 producing codeine syrup. There are many. But we see in addressing it, we need to ask ourselves questions. Do we need codeine syrup at all or cough syrup at all in Nigeria on that scale? The answer is no. Those in the medical profession told us that Nigeria does not have a cough epidemic. So if there is no cough epidemic, why are we consuming cough syrup at this level? May I also tell you that years back, Professor Olukoyi Ransom Kutu removed cough syrup from the essential druggist, because according to him, that is not the treatment for cough. The treatment for cough is to find out, why is this person coughing? Is it infection? Is it lung congestion? Is it allergy? Is it foreign body? We need to find out. Cough syrup, particularly the codeine-containing cough syrup, is to suppress the cough. But the physicians will tell you that maybe what the treatment should be is to allow that person to cough it out.
What would you say to those who say that that documentary woke you up?
That's not true, because if a committee was working, submitted a report for after 4 months, why would that wake us up? No.
Why did it take so long to have the action? Why did it take so long to take the decision to ban codeine?
When the committee submitted its report on April 12th, we cannot ban codeine the day they submitted the report. That report has to be internalized. It was sent to the Department of Food and Drug Services. We need to look at the implications. We need to look at the steps. We need to talk to various agencies. We need to have the legal people to say, look, can we do this? So that takes time. And we had all these assurances. Yes, it is within your powers to do so. You need to talk to the agencies that will enforce it. Otherwise, you make a pronouncement, nothing will happen.
Are you saying we've not done this for the cameras? I mean, there's always the...
And also, let me tell you, Kano banned codeine-containing syrup. Sokoto banned it before now. So it's not nothing new. What we are doing is just giving them the federal support.
How effective was that ban? If they already banned it and it was still high in consumption?
It will be high in consumption because there was no federal support. The real issue is to say, look, we stop giving permit to those who import the codeine. Once you ban it, you are going to reduce supply. So we wanted to reduce supply. Then we will now, since it's a prescription-only medication, you are not supposed to sell it across the counter. You are also not supposed to market it by non-pharmacists. So there are many things involved. And to me, what we are now doing is to give them the federal might. Looking at distribution, looking at sales, and also making sure that we keep records. And that's what happened. BBC helped us because they identified those 3. We went to the 3 and said, can we see your records? And they were not cooperative. Why
did you not know about the 3 or even more about the companies producing? You've not had a meeting with those people before.
You mean we'll have the meeting with the 3?
Not the 3, but even any company producing cough syrup with codeine, and wonder how come it is that it's so easy to obtain on the black market. Kano has dealt with this problem for God knows how long. NDLEA is constantly doing raids on,
They are doing raids. We are also working on the distribution system. I've gone to Aba, I've gone to Onitsha, meeting with wholesalers. I've gone to Lagos, set 2 quarrels, and we gave them deadline. The deadline was extended. They pleaded that we should extend the deadline. And by January 1, 2019, we will ban distribution across the place, except in designated areas. I flagged off the distribution center in Aba. So we've been working. This has been on for over a year.
Would you say that the actions that you have taken in recent times have been more drastic and perhaps could have the potential to be more effective compared with all that you have done before?
I think the action we took in banning supply is just one out of several available to us. We're working with wives of state governors, looking into rehabilitation. We've elevated and upgraded 11 hospitals to become treatment centers. That did not happen today. We've trained over 1,600 people across the country in identify suspects, those who are addicted, those who have withdrawal symptoms, and how to manage them. We didn't do that today. So, to show you that we've been working. Well, we couldn't have trained 1,600 people overnight.
Let's talk about rehabilitation. You've talked about how you've trained people to, you know, in certain centers.
And now we've upgraded 11 of our tertiary institutions to become treatment centers across the country.
You do know that the people who are hooked on codeine will definitely be looking for ways to get the codeine. What do you also say about, you know, the black market? How are you going to follow what could happen on the black market?
Well, what we need to do is more intensive cooperation activity among the various agencies, NDLA, NAFDAC, Pharmaceutical Society of Nigeria, and so on, all working together to track them, trail them, and they will succeed.
So
no country in the world has ever reduced to zero drug problem. But what we want to do is minimize it. That doesn't become a societal challenge.
Under whose purview is rehabilitation going to be housed? If we already have a major challenge with our primary health care system, and we know that, you know, things done by wives of state governors are usually pet projects and never continue after the tenure of their husbands, what is going to happen to this system of rehabilitation?
We intend to institutionalize it. So it's not just going to be one of these off-cuff things. The wife of Mr. President is also driving this initiative. We're working with the state governors. So, and the whole intention is that in each state, there will be a rehabilitation center. Once we have a rehabilitation center in each state, beyond the level the federal government is handling, because we need more than a level. The drug problem is beyond codeine. The drug problem is nationwide. People, they sniff not only tobacco, hashish, they smoke even urine, fecal materials, petrol, aqua, and even fecal matters. So it's beyond codeine. So people just see codeine as one, but it's beyond all those.
Professor, the joint health sector has been on strike for quite a while now, Johesu, and they have been asking for a number of things. Some of them, they say it has to do with their salary scale. Doctors, of course, have said they're an illegal body, that they ought to be taken as separate entities. They don't recognize anybody called Johesu. But you are dealing with them all the same.
Yeah, because we consider them a reality. And we also believe that doctors are entitled to their opinions, but we will decide on who to talk to.
But you have also said that it seems that what they're asking for is parity, which you cannot grant. Is that right?
That's correct.
They have said that what they're asking for is not parity, that there is relativity in what they're asking for.
I think what you need to ask yourself, what did you say? Can I get you right?
They said that there's relativity in the system that they're asking for.
There's none. Because what they presented to us was the same salary scale for doctors. Look at it, it's the same. They did not even vary it by 1 naira. And we said that will only create chaos and precipitate another crisis. Since even before independence till date, there has always been relativity between the salary of the doctor and the non-doctor. And this must be maintained. I'm for improving the conditions of service of the health workers and for reviewing their salary scale. But we cannot have parity, because that will lead to another round of argument. We cannot solve a problem to create another one.
Now, they claim that that the parity has already been observed, because you cannot just come in onto a certain level when you come straight out of school, when you are a worker under the Johesu umbrella, that there is a certain level which you must be on, but that for doctors, they get to jump a certain number of levels because they already come in. You know, they're coming from medical school. They don't start on the same level as Johesu workers, and they believe that that's already creating relativity.
They do not have the same scale. the doctor scale starts around the 9 of the USU scale, or the what we call CONHES, as against the COMES. But when you look at the two scales, what USU is asking for is to say, look, whatever is there, we want to have it on the CONHES scale. And we said, no, go and negotiate yours. You can even ask for something higher than the doctors. I will be talking. But to say you must have naira for naira, the same. I don't know what else, because he said it's equity. I don't know what that means. To me, it is the same. Maybe we should just be honest with ourselves and say it's the same. You are asking for the same template, word for word, figure for figure. And we said no.
Now they have decided they're going to call all their members. I mean, initially the strike was at the federal level. Now they're asking for their members in the state and local governments to join in as well. What effect do you think this is going to have on the healthcare sector, and how do you hope to mitigate it?
Well, we're talking with them because we're at the bargaining table. We met last night, we adjourned, we are meeting again tonight, and so we've not stopped talking. As far as we are concerned, we will not stop talking as a government, but we will keep on pressing them to realize that we must not create neither of them can function without the other. If USU comes back to work and the doctors are on strike, we're back to square one. But let me also say that what we have is really indiscipline in the health sector. When you look at other sectors, if you look at the construction industry, architects are recognized as leaders in the industry. When you look at scale of fees for consultants, the architects take about 40% of the total fee. The structural engineer is there, the others are there, and nobody challenges the architect to say, oh, as a structural engineer, oh, I must this, as an electrical engineer, oh, I must, as a structural engineer, I must. No. The architect is recognized as the leader. And we must come back and say in the health sector, there must be a leader. We can't all be leaders. And
you think that doctors should be the leaders?
Oh, it's not, I think. That's what it has been. Even historically, there must be a leader.
Yeah, they say that, you know, that is not necessarily the case. I mean, in trying to make doctors the leaders...
It's not trying to make the leader. What they are trying to do is to de-recognize the doctor as a leader. And that will not help us. There must be a leader. There must be a general. You don't fight a war without a leader.
What do you say to those people who say that, yes, doctors can, of course, I mean, people say when you go to the hospital, you don't go there to see the pharmacist, you go there to see the doctor. But then it doesn't mean that doctors must lead hospital administration, for instance.
No, there are two different things. Let's separate leading the health sector from leading the hospital. I hope you get what I'm saying.
Have we separated it in this country? It would seem that they mean one and the same thing to us.
Well, initially, doctors did not head the hospital. Doctors did not head the hospital. They were made to head the hospital when there was a crisis. And even initially, there was some separation. The provost of the College of Medicine was also the chief medical director of the hospital, some form of harmonization. But by 1985, there was a problem in Louth. And I think Chief Obasanjo, then head of state, wanted to address the problem. And he could not discipline the doctor in the hospital because they said, oh, he was employed by the university. And that created a situation where I said, look, we must separate this leadership. If I wanted to punish the head of the hospital and someone tells me I cannot punish him because he is also holding a position in the university, and that led to the separation of the two. So we separated the position of the chief medical director from that of the provost. So now we have two different positions. But to me, that is also historical. But really, what matters to me is not much as to who is heading the hospital, but about who is leading the health crusade, who is leading the battle against diseases, against ill health, and that has to be a doctor.
That has to be a doctor?
Yeah.
Well, let us also talk about...
That does not imply that others are not important. In fact, my position is that the most important person is not even the doctor, the nurse, the pharmacist, or the laboratory scientist, or the radiographer, but the Nigerian citizen, the patient.
If that is the case, if the patient is the most important person, how do we then ensure that the rivalry which has besieged or, you know, dealt with the health sector for quite a while now is brought to an end? It doesn't look like there's any end to this rivalry.
It's peculiar to the health sector. And I'm not sure we have that in other sectors. And
is it peculiar to the Nigerian healthcare sector?
It is peculiar to the Nigerian sector. Because in other sectors, nobody even cares. You do your work happily and you move on.
So what can we do to end it? I mean, if it's just Nigeria, I mean, Johesu asks for demands, NMA says, no, you're an illegal body, you know, we don't even recognize you. Well, thankfully, the Minister of Health who needs to deal with them recognizes them.
Yeah, we're talking to them.
How do you begin to say, we cannot continue like this? The rivalry in the sector is also killing the healthcare sector.
Unfortunately for us, we started by bringing all of them under the same roof. Last year, we had 2 sessions of conversation. They said, look, we must come together. We had 2 sessions, and unfortunately, what has happened now has created a setback. But we still must come under the same roof and talk. Because without coming under the same roof to talk, we are not going to really offer the health care that our people deserve.
How big a problem is it for you?
It's a major issue.
As minister?
It's a major issue.
Do you think it's something you can end before your tenure runs out?
I believe so.
Let's talk about corruption in the healthcare sector. Some people will say that to ensure that the monies that are earmarked, we've talked about how, you know, we're not earmarking enough. I mean, you have complained of underfunding of the healthcare sector, and you're looking for more money. But then there's also effective spending, efficient spending of the monies that are allocated, ensuring that whatever it is that goes there, the little that we have there is showing. I mean, we're getting value for money for whatever it is that we spend there.
Well, Nigeria is a country where people cry wolf when there was none. People talk about corruption, but it's difficult for them to bring to the table real evidences to justify that allegation. You recognize that there was even a press release by Johesu saying that it is not the human resources, it is not funding that is mitigating against delivering health, but the corruption in the health sector. I can see it. Do you know the real corruption? About 80 to 90% of the resources is used to pay people. That, to me, is the corruption.
Used to pay salaries, you mean?
Yes, salaries. That's the corruption.
You think it's corruption to pay staff their salaries?
When they are not delivering the service, is that not corruption?
You mean when they're on strike?
Even when they are not on strike, are we measuring the input?
Whose job is it to measure it then?
Are we measuring the input? That's why I've directed CMDs to do audit, find out, are people really working? I was instrumental to a Nigerian getting a position in Northwestern University. It's just been made a chief of infectious disease. The last time I had a conversation with him, he said, Prof, thank you for all you've done for me. I've just been made chief of infectious disease. Do you know what I was able to find out? That the matron in the clinic would document the number of patients that was seen by each doctor. You had that type of checks and balances. We need to document what did people do. When did they come to work? The laboratory person will have to justify working in the laboratory and getting paid. How many assays did this person run? It's not just about number. What did they do? So we need to, and when I addressed the chief executives and the chairman of the boards, I told them we need to do audit. We need to justify our pay. We need to work for our money.
How was that received?
Oh, I'm sure well received. We are going to do a retreat for all of them so that we can give them some guidance. We are going to strengthen them. We are going to do workshops. We need to document what people do daily.
I've had cause to use the National Hospital, which is supposed to be a center of excellence.
Oh, it is.
And sometimes
it is.
Not to my own estimation.
Well, it depends.
The people whom we saw, thankfully, I mean, they were excellent people. They were very good at their jobs.
Good.
But then when you look at the environment under which they operate, you have to ask, what is there really for doctors not to want to work outside of this country? What are we doing to ensure that the people who work in our hospitals have a conducive environment for them to work in and not want to leave the country?
When you say conducive, what do you mean by conducive? What exactly do you mean? Because I've seen people.
Have you been to our healthcare facilities in recent times?
I've been to many.
To many of them. Are you impressed by what you see, or is it that...
That's why I'm asking you.
Because I also know.
I want people, you see, I've had to face a group of people, and they say, oh, we don't have this, we don't have... I say, have you been to any other hospital outside this country They said no.
I'm going to be very Adewole.
Yeah.
Thankfully,
So,
I have.
yeah.
I have been to hospitals outside of this country. I also know that when ministers and commissioners and important people are coming to pay visits, I know that the hospitals wear a fantastic new look. You know, the beds are made,
well,
even where they claim that there are no sheets, the sheets are done.
The day I visited National Hospital, I got there at 7 a.m.
Was it a scheduled visit?
It wasn't. 7 a.m. I was at the gate and I said, CMD, I want to pay a visit to your hospital. Are you around? And to my surprise, he was in his office. 7 a.m. 7 a.m. And I walk around. When I visit hospitals, even when you plan to take me to some route, I take the other way. I visit your toilet. I want to see what your linen looks like.
Are you happy with what you've seen so far? Or do you think that we could do far better?
We could do better because, like I said, anybody who says we are there is not really a progressive person. Whatever we have can always be better. And that's my position.
Let me quickly talk about corruption only recently. There were accusations against the NHIS Executive Secretary, whom you had cause to suspend. He's been recalled now, and there's been total silence on why he was recalled. Why did you suspend him in the first instance?
Well, the suspension came about because there was a recommendation from the permanent secretary who recommended that we should suspend him to allow for free investigation of the allegations against him.
Now that he has been recalled?
The committee produced a report which we submitted to Mr. President through the Office of the Chief of Staff. And at the end, the President, in his wisdom, said we should recall him. And he was recalled.
Were you consulted?
Well, I'm not going to tell you the inner workings of government, but Mr. President doesn't have to consult me before recalling someone. Mr. President did not consult anybody before appointing me a minister. Do
you think that it undermines your office?
I don't think so.
If you suspended the NHIS Secretary as Minister of Health, some people will say it's an agency under...
It's an agency under me, but
Ministry
the buck
of
stops
Health.
on the table of the President. Who takes the decision? He has wider view of issues. He has the opportunity of listening to advice from all sides. And at the end of the day, he says, let him come back. I can't query him.
Do you think it undermines your office?
I don't think so.
Do you think you can query the Executive Secretary in future?
I will, if there's a need for it.
Do you see any need for it right now?
If none, if anything comes up again, I will do so. I'll query him.
Well, some people have said that, I don't know if you've seen an article on this, some people have written on it, they believe that you haven't quite shown, they said that the allegations against Professor Yusuf were monumental corruption and brazen regard for due process. The panel that suspended him had the EFCC, the ICPC, the DSS as members of the panel. They turned in a damning report. The suspended secretary of the NHIS, the panel unearthed bogus trading contract and nepotistic tunnels and drain pipes. You accepted the findings of the panel.
Yes, I made the recommendation.
You suspended the NHIS secretary.
Before the report, I suspended him. When the report was submitted to me, I forwarded it to the President and made recommendations. They remain recommendations. The ball stops on the table of the President.
You don't think you need to protest that, Mr. President, this could actually look bad on us?
Well, the way to look at it is that you must accept your limitation as a minister serving under a president. It's like a director under me making a recommendation. I could say no. Because I take responsibility and I might have other reasons for saying no.
How would you describe your relationship with President Buhari?
Excellent.
Excellent. It's interesting you say excellent, because considering the fact that in 1984 you were president of the resident doctors, and I think you led them on a strike, and the president, then the head of state was not happy. You went on exile, and now you are back as a minister for health under his administration.
It shows him as a man with a large heart. Under normal condition, he would not have appointed me minister. But that singular act, to me, shows the president to be a thoroughbred statesman, someone who would look beyond petty issues in taking decisions and making appointments.
What about you? How does it affect your view of the president? If, as at that time, you thought you were exercising your rights and you were trying to, you know, bring forward the agitations of the doctors at that time, but you were hounded into exile, how do you feel about?
No, I wasn't hounded into exile. I went on my own. I think it was a matter of policy. People need to know. Doctors then were not even fighting for salary increase. There was a regulation brought forward that necessitated doctors paying for treatment in hospitals. We thought that was wrong, and we protested against it. But other issues crept in, and that led to a nationwide strike. And government then sacked all of us. Not only sacked all of us, there were attempts to arrest us, and I went on the ground. And at about that time, I was also due to go for my 1-year abroad program, so I left.
The point is, how do you then view him? How did you view him then as head of state? And how do you view him now as president?
Differently.
Why?
Because of my exposure, because of my understanding. And going abroad also helped me. It changed me as a person. Let's be honest, it changed my perception about the health sector. It changed my perception about strikes. And by the time I came back, I became a changed person. And I went to the NMA summit and said, look, doctors must never go on strike on frivolous grounds. And secondly, even when you have a strike, it must never be total. And that strike helped me because it exposed me. I saw a different side of it. I also felt that unions must be responsible to their membership. No, there's nowhere in the world where unions would go on strike and say they must be paid.
You talk about how our centers for excellence are excellent. I mean, I mentioned the National Health Hospital. You seem satisfied with the services that they're currently providing.
I think you are quoting me out of context.
Well, you have the chance to...
Saying I'm satisfied,
yes,
can never be from me, because I always believe they can do better. In fact, one of my major weaknesses, I rarely commend people. But sometimes people who are close to me, they know when I'm quiet, that means they're doing well.
Do you think that the fact that none of our centers of excellence is good enough for our president to seek medical treatment in, is it some form of indictment on our healthcare system?
I don't think so. There's also a Nigerian angle to it. Nigerians are so secretive. We are also lax about data and information management. Let me tell you, the average Nigerian does not want his medical condition exposed.
Are you saying that the president has gone abroad for treatment because he doesn't want his medical condition exposed, not because he do not have the expertise here?
I cannot speak for the president because he's an individual. But I've interacted with a number of my colleagues. And I know there's always a penchant to not to go to public hospital. They want to go to a private hospital. And when you ask them, say, oh, when we are there, whatever we have is well managed and the information is well contained. That's one. Two, there's a doctor-patient relationship. When you are used to a doctor, you want to keep to that doctor. I have a physician in Ibadan. But by the time I got to Abuja, I didn't want to consult anybody. But I love doing regular checkup every year. So I had to look around, who can I use, who can I talk to? Until I met a lady, a professor, who said, look, I can give you this checkup. And I've been having my regular checkup every year. My advice to anybody is treat yourself the way you treat your car, regular checkup. But let me also say clearly that if you are being treated for something or you are being checked up for something, you don't want to just go to another doctor. I'm a gynae person. What will be shocking to you is that when you are seeing a lady, that lady will not want to see another doctor, no matter the circumstance. When you have course, and that really started even during my training, you had an interaction with a patient, and you say, oh, man, I know what is wrong with you. You say, no, go and read my records. I've spoken to your boss. Oh, I've done this. I've spoken to another doctor. So there's that reluctance. So I don't want to really attack the patient-doctor relationship, which I suspect the president must be handling. And I also believe that the president has a right, as a person, to decide on where to be treated.
You don't think it's an indictment on our healthcare system?
I don't think so. Honestly, I don't think so. I don't think so.
Do you think that it looks good, though? I mean, that our president is not able to get health care here. It's not the first time that any president is having to seek medical treatment abroad.
Because we are making it look as if the president is the only one who goes out. I think that's wrong. It's not the only one. We want to see it happen. It's going to happen. He has approved the upgrade of a facility. But let me also tell you, the president asked his son to be treated in Nigeria. Even when people are clamoring that the son should be flown abroad, he said no.
But eventually he
was. I met
was.
with him. No, just went to Germany for rehabilitation.
But he went abroad.
But he had the surgery in Nigeria.
But he went abroad.
No. You see, you can do rehabilitation anywhere.
Honorable Minister, he traveled out of this country.
What for?
We do not know, but he traveled out after his accident.
I'm telling you that the son was treated in Nigeria. Take that from me, as the Honorable Minister of Health.
I'm not having, what I'm saying is that to the ordinary Nigerian out there, yes, we know that he received some treatment here in Abuja, but we also know that after that he was out of the country.
Don't people go out even for holidays? Don't they go out?
Was he out for a holiday?
No, that's the holiday.
Oh, it was a holiday?
Oh, it was.
What do you make of it? I mean, you saw the tweet of the First Lady, Mrs. Aisha Buhari, saying, talking about, the Aso Rock Hospital, the Aso Rock Clinic, and how syringes and basic things were difficult to come by.
I heard her saying so physically.
Yes.
And the next day I went to the clinic.
How did you feel about it?
I went to the clinic. The clinic is not under us. The clinic is not under us. I went there. There are systemic problems with the clinic, and I made some recommendations. So I commended her for bringing it to light. I couldn't have known without her saying it. So it wasn't a tweet. She said it openly. She's forthright.
Do you think that we should have a system where Nigerians can voice their, disenchantment with our healthcare system as she was able to?
Oh, I would love that.
What are you doing to put it in place?
Oh, I received text messages. There was a day I was woken up by someone who said, my wife is in labor, my Tama hospital. I drove there.
Honorable Minister, you can't handle it all by yourself. Shouldn't there be an institutional system where we can complain?
We're working with NCC. NCC are giving us some numbers, so we're working on that where we want to receive your complaint. But let me also tell you that some of the complaints are frivolous. We're overwhelmed. When you investigate some of those complaints, they are false.
What do you say to those who say that a lot of our doctors are traveling out of the country because they're dissatisfied with what is happening here? How do we hope to keep those that we train here?
We can't keep all of them here.
True.
That's the truth.
But how do we keep the majority of them here?
There's migration. Well, it depends on the absorptive capacity. Federal government has taken more than enough. We have no vacancy. If you are qualified today, we can't take you. We're overwhelmed. We have more doctors than we needed in the tertiary system. The problem is at the state level. Unfortunately, it also has to do with pay. When you look at the pay structure at the state level, they cannot pay the federal. And when they cannot pay, you can't stop people from looking for better pay. We can't absorb them. If I want 100 doctors in tertiary hospital today, I'll get it tomorrow. Well, we don't. We don't have the space. We don't have the money. We
do not know when your tenure as Minister of Health will end, but what do you want Nigerians to, take away from your administration as Minister for Health?
Well, we want to be known or really remembered for restructuring the health system and also putting in place a structure for keeping Nigerians safe with respect to public health. And that's what we are doing with the Nigerian Center for Disease Control. It's to be one of the flagship projects of this administration, building capacity to tackle public health outbreaks.
Honorable Minister, thank you for coming on Hard Copy.
Thank you so much.